Welcome to the Game-Changing Women of Healthcare, featuring exceptional women making an impact in healthcare today. Together, we dig into the many healthcare issues we face today and how these innovative leaders are working to solve them. And we celebrate our guests' accomplishments, setbacks, and the lessons they've learned throughout their careers. I'm Meg Escobosa. Join me in conversation with some of the many brilliant and courageous women on the front lines of the future of health. Hi, everyone, and welcome to the next installment of the Game-Changing Women of Healthcare. I'm your host, Meg Escobosa. Today on the show, we have Dr. Monica Soni, Chief Medical Officer of Covered California, which is a free service that connects Californians with brand name health insurance under the Affordable Care Act. Dr. Soni received her medical degree from Harvard Medical School and continues to see patients as a primary care physician. She's also a board member for Mercy Housing California, one of the country's largest affordable housing organizations. And previously, she served as a commissioner for the Los Angeles County Hospital and Healthcare Delivery Commission. Monica, welcome to the show. Thanks so much for being here.
Thank you so much for having me. Thrilled to be here.
Let's start with the basics. What is the core mission of Covered California, and who do you serve?
Yes, well, you did a great job in the introduction. But Covered California really is California's Obamacare. We now serve actually nearly 1.8 million folks. It's record high for us from the top of the state all the way down to the border. And our mission really is to make sure that we are providing affordable, high quality, equitable care to all Californians.
Access to care is such a key issue. Can you kind of give us a state of the union? What is the state of access today, and how do we compare to some other states?
Yes, that's a great question. So amazing strides have actually been made in California. We were almost up to 17% uninsured rate back before the Affordable Care Act got passed. We are now down to 6%.
Wow.
And those improvements have been actually sort of disproportionately benefited communities of color, Hispanic Latino folks, and also Black African-American folks in California, and certainly low-income folks as well. So we're very proud of that. Are we the best? No, there's a couple other states that actually beat us. So Massachusetts, I think Hawaii also have a little bit lower of an uninsured rate. But I mean, in that 10-year period to make the strides that we've made, really a lot to be proud of.
Yeah, it would be great to hear what are some of the things that you've been able to do to enable that, and what barriers have you been able to overcome for people?
Absolutely. I mean, we're lucky that we're in such close partnership with other California public purchasers. So over the same time that Obamacare got created, we also had the ability to expand Medi-Cal. So those two things happening in tandem have really been critical and paramount. And Medi-Cal this year, actually, 2024, expanded to low-income folks regardless of documentation status. So that was really sort of the last area where it had not been possible to actually insure folks. So that was really meaningful. And then on the Covered California side, when we first opened our doors, people were literally lining up around the block to be able to get coverage. I hear stories all of the time of, I heard a woman who was telling me that she cried the first time she bought her own policy because she had a history of breast cancer, had, pre-existing condition, had been unable to get the care that she needed before the Affordable Care Act. That changed, and she sort of lives in this state of gratitude for what the ACA did. Today is a very different issue, right? The 6% that remain, they know Covered California exists. Some of them are really making a choice between other needs, other priorities, and the cost of care, despite frankly, how affordable our services are at this point in time. It's less a knowledge gap and much more, or we haven't done a good job at Covered California in maybe making the business case to them as to why insurance is so important.
Yeah, I remember when Obamacare was starting, there was such pushback against the penalty if you didn't get insurance. What is the status with that? Listeners may well know this, but I'm curious where we are on penalties versus carrots.
Yes. Well, the last time we had a Trump administration, there was a lot of repeal and replace. And one of the things that got really moved out from the federal landscape was the individual mandate. But California stepped back in and said, well, we are going to have our own individual mandate. So that does mean that in the state of California, there is a tax penalty if you don't have continuous coverage. I will say, I'm proud to say that those pool of funds that have been collected from true penalties actually have been redeployed back into covered California to reduce out-of-pocket costs. So this
Mm-hmm.
year, plan year 2025 is the highest level of affordability we've ever had to be able to offer folks. We're actually wiping away deductibles for the vast majority of our enrollees and have reduced out-of-pocket costs for primary care, for generic drugs. And I didn't mention this, but 1 in 4 of our enrollees pays $10 or less a month in premiums. So
Yeah.
it's incredibly affordable at this point in time.
So fantastic to hear. When we first learned about Covered California and engaging with you and your responsibilities, you talked about 3 arms that you are focused on. Can you describe the 3 arms? And then we want to talk first about the accountability program.
Yes, for sure. So I've been in Covered California. It's approaching 2 years. I feel so lucky to be here. As you mentioned, I'm a practicing primary care doc. I was in clinic this morning. And to be able to sit where I sit and think about both how to serve the 1.8 million that I'm responsible for, but also think about the broader landscape in the state and also nationally has been incredible. So our primary relationship is with health plans, the Kaisers, the Anthems, the Blue Shields of the world. And we have a few mechanisms to make sure that you don't just have an insurance card that you can't use anywhere, but that you can choose the providers that you want to see and that you actually get high quality and, like I said, equitable care. That's one big kind of chunk of what I focus on. It's what we call health plan accountability. We have contract mechanisms in place around that. And then we have our own actual data set. So we actually get full claims directly from all of the plans. And so it's not just a matter of you tell me you're doing a good job. It's a matter of I can run my own analytics and see what's going on. And I can disaggregate all of my own data to see where there are disparities or inequities. And so that's another huge chunk of what I spend my time on is really letting the data guide us and lead us as well. And then I hope this is the last arm that I shared. The last arm. No, I was like, what did I say? It's thinking about affordability, right?
Mm-hmm.
Like we still here, and this is the predominant reason we still have a 6% uninsured rate is it's still too unaffordable for folks. And that no matter how many subsidies we have coming in from the federal government or from the state, it's the underlying cost of care. It's the unit costs, which continues to increase for all of us, regardless of our source of coverage.
So even patients who are getting insurance through Covered California are getting those additional bills that come after the appointment. They're getting that supplemental, hey, there's this $23 from your last doctor's visit.
It is true. And we have standardized benefits so that regardless of what plan you have chosen, primary care visits can only cost this much in terms of copay, and your specialty visits can only cost so much. But there are folks that are, again, making decisions about rationing their budget. Frankly, this is what we've been told. Do I go to the grocery store? Do I pay for the transportation to make it to work? Or do I pay my premium or this out-of-pocket cost for that primary care visit? So when you have someone making choices like that, $10 actually is quite a lot in terms of a copay for a visit.
And for the health plans, the commercial plans that are participating, the brand name plans, what's their rationale for being a part of this? I mean, it seems like they've got to do more work, actually, to participate and to make themselves available to this population. Do you see any potential risks to losing some health plans because they have higher, accountability expectations that you guys are putting on them?
Yeah, it's a fantastic question. And I love it because the truth is we are not an all-comers market, right? There are other states where it's a little bit more flexible to come on. And in those states, you have just a proliferation of plans and also offerings. We don't. We have a very high bar to come in. We are over 10-year stable marketplace. We can be picky and we can be choosy. And if you can't prove to us that you're bringing higher quality, more providers, some other benefit to our consumers, we don't want you here. And if you've been here and you cannot show us that you actually continue to deliver on that mission and vision, we are fine for you to leave. And we have had a couple plans that had exited over the last couple of years, mostly for financial viability reasons, but to your point, because our expectations are high and some of them just couldn't quite cut it.
So you do have some data that you've looked at. Do you have those results? And can you share a little bit about what you've seen so far and how are you feeling about them?
Yes, I'm feeling great. So maybe I'll start with a quick background, which is, as I mentioned, there's, three public purchasers in California. There's our Medicaid agency, there's us, the exchange, and then it's what the employees are covered through, which is called CalPERS. And the three of us, we really have a lot of market power. We represent over 45% of all Californians. And so we've made a choice to do things together, same contract language, similar programs, same measures. And so the program that I was sharing with you before is called our Quality Transformation Initiative, done in alignment with those other purchasers. And we kept it simple. We had seen really stagnation in the quality of care that had been delivered in a quantitative way. We could see we weren't actually getting a lot for our dollar in terms of preventive care, cancer screenings, immunizations for kids, et cetera. So we decided to put some money on the line. So all of our health plans have a percent of premium at risk. This first year, it's 1%, and it will go up 2%, potentially 3% to a cap of 4% if they don't deliver on high quality care. We kept it simple: diabetes control, blood pressure control, colorectal cancer screening, and childhood immunization. This is just standard stuff that folks should be getting if they have insurance. But we had a wide spectrum. We had some plans that were hitting it and some plans below the 25th percentile nationally. Wow. So it's just, right, really pretty bad. And I will say that between 2022 and 2023, which is the results that we just got in and shared publicly, we saw the most improvement we had really ever seen over the course of our existence. We saw that 12 out of our 13 health plan products, because we've got HMO and PPO, had an increase in performance, both for diabetes and for high blood pressure, and 10 out of 13 actually saw an increase in their colorectal cancer screening rates. And you might say, oh, well, that's artifact, it's background noise or something like that. And so we took a look. We said, well, did our improvement, and even if you do a 3-year trend, did it outstrip other lines of business? Did it outstrip national performance? And it did. And when you hear the plans actually shared this week at our board meeting, we asked three to come, like, what have they done? One of them actually said it was, frankly, they said it was only because of this program that they started to invest in quality. That's what was said in the meeting.
Yeah.
Publicly. Yep. and that's the truth. There really was no financial imperative or business reason to invest in quality until we started to have this downside risk.
Penalty, yeah.
Penalties. I'm sorry to say that that's just the reality of motivators when healthcare is a financial game, right?
Yes, and I'm curious if their providers, who they contract with, are they sharing best practices? Are they sharing what they're doing as well to get their patients in for these preventative treatments or screenings?
Yes, I think in the best case scenarios, and of course the plans, they threw a lot at the wall to try to see what's stuck. But in the best case scenario, there was sort of multiple things happened. One was just, it's not that easy to get in to see a provider, right? We still know that there's workforce shortages and there's not a lot of after hours access. I can't even get my kids to get their vaccines on weekends or evenings. And I have a very reputable primary care provider whom I love, but that's not how it's set up. And I would have to take the day off of work and pull my kids out of school to get them vaccinated. So we know that that's still a challenge. And so I think credit to our health plans for mailing, colorectal cancer screening kits home, sending blood pressure, machines home, thinking about more accessible forms of access. They definitely put incentives in place too, right? A little bit of money to get your, cancer screening done. That works for folks too. The evidence suggests that. And then to your point, they changed some of the provider contracts. They put more money on the line, upside opportunities for providers too in areas that were really hard. And the closer that the relationship has been between the plan and the providers, the more effective they are. The data is better. The understanding of on-the-ground issues is better. I still think there's a lot more work to happen in that space. I don't know that it's as intimate of a relationship as it could be, but the more that it is, I think the better that it will be.
Right. This issue of friction between payers and providers is a longstanding challenge. And obviously, where you can find shared incentives, shared goals, that's where you're going to make a big difference. This kind of brings me to perhaps to listeners who might be entrepreneurial or in the private sector. Can you think of things that the market can do to serve, make this better, help you with your goals as well? Is there anything that you have a wish list for that perhaps our audience can start tinkering at and, figuring out?
What a good question. I have a very long wish list. Well, I think one of the saddest, sort of states of affairs is still how disconnected and firewalled just information is.
Yeah.
And in sort of some shocking ways. I'll share a story from just like today for me in clinic. I saw a gentleman who had just had open heart surgery a month ago and came in on blood thinners, but the visit was just like, oh, needs like blood thinner, titration. I had no records. I had no idea what was going on. He was super with it, but like had a kind of sketchy, a few pieces of paper and some handwritten notes. And so it was through detective work and guessing that I was like, well, are you on any antibiotics? And oh yeah, I have this pill.
Right.
What is that pill? Starts with an L. Is it linezolid? Yeah. I mean, that was how I spent this morning. And it's like, that's unacceptable, right?
Right.
I'm sitting in front of an electronic health record. I have a telephone right here. I have two devices, personal devices in front of me. He has his own device. How is it that I cannot understand what happened in this critical hospitalization for someone sitting in front of me? So that still to me remains a huge barrier. And I believe that we have not fully kind of democratized or freed the data. Why doesn't he have it on his device? Why isn't that something he could have pulled up right in front of me? So we have contract requirements trying to encourage that and support it, but we're a few steps removed. And so it's been really hard for us at Covered California to inflect change in that correct data exchange space.
Yeah, and just on that point alone, is the provider protecting themselves by keeping this data to themselves? Is there something that's just inherent in the dynamic that's promoting this that we just don't think about, that we can get to the root cause and get rid of that problem?
I think there are very select areas where that's true and where I respect why those kind of firewalls exist. So some has been in reproductive health, right? Especially as there's been shifts in that. So I'll leave that kind of over there. I don't think we can assert free all data. In the past, sort of HIV/AIDS was another one that folks just didn't feel like they wanted that information freely shared. The stigma has changed. I feel there's a lot less resistance about that. And then substance use disorder, mental health would be kind of the other one where folks don't necessarily want their information out there. But frankly, in this situation, it was none of those things. It was really just like out of sight, out of mind, right? Like this person's discharged. I took their stitches out. Go forth and figure it out. I was like, it's a little bit crazy. Like here I am trying to figure it out with nothing to go from really at all. So I think, I don't think it's provider community driving that is my feeling.
Yeah. Yep. Just the nature of the structure of our system, fragmented care and fragmented technology.
And fragmented payment systems as well. Absolutely.
Right.
Okay. Next thing on my wish list, I think is, we are trying to do everything we can from our seat to address the persistent disparities in care along a number of demographic factors. It's not just race and ethnicity, certainly income level, the type of insurance that you have, where you live, regions, rural, urban, super rural. But I do think when we try to engage with our health plans around this, there's a feeling of overwhelm. And I think the feeling of overwhelm comes from, well, how can you solve every different communities and every different, person's problems? And to me, it's so sad that that's kind of the feeling. Instead, what an opportunity to learn from community, learn from folks with lived experience, think about what a culturally tailored or specific intervention might be, and then scale it once it's sort of been shown that it works in that circumstance, appreciating that not everything lifts and shifts. So I think that's when I would just love more community voice and power sharing everywhere. That would be on my wish list for sure.
I totally can see how that would be impactful. Those are meaty and worthwhile and seem like they would actually have an impact. So you are part of the work that you're doing is the population health investment.
Yes.
I think this is so exciting. I know you're planning for it in 2025. Can you talk about the vision that you have and what you hope to achieve, and maybe even speak to if you have data and evidence or anything that kind of illustrates why you believe this is a good strategy and what impact you're hoping to accomplish?
Yes, thank you for that question. So the Quality Transformation Initiative, we're thrilled that it worked in the first year, but we didn't hit it out of the park, right? We're still going to be collecting $15 million from our health plans for underperformance on those high impact measures. And
And
our
what's
hope is that.
what's the ratio? Like that's 15 million out of, I mean, what percentage does that represent?
Yeah, that's actually a good question. I don't have my denominator right at my fingertips, but what
Okay,
I'll
no problem.
say is that what we had estimated was that it would be more like 29 million had they not improved. So we saw some significant
Okay,
improvement between one year and another,
nearly
which
cutting
is
it in half.
nearly cutting it in half. Exactly. So I think it can be done that we
Hmm.
collect no dollars if the plans continue to improve, which is what we want them to do. But in the meantime, we had sort of this ancillary benefit of dollars to play with a little bit. And I think traditionally, most programs like this, the money kind of flows back to the health plans. And I had just started my job here. And so I asked, like, does it have to? And the answer was no. And so then I asked, well, what else could we do? And appreciating that we're not the smartest people in the room and this is not our core competency, we pulled together an advisory council, which included a current covered California consumer, folks from a bunch of different industries, health plans too, clinicians too. And we did a bunch of literature review and we pitched stuff. We were like, well, what about this? And how about that?
Oh,
But the
nice.
most important, yeah, it was super fun.
Yeah.
But the most important part was that we started by listening to current covered California enrollees. So to some of the questions you asked about data, we first just called a bunch of folks who were part of that initial quality transformation initiative and said, hey, what's helping you be healthy and well, or what's getting in the way of you being healthy and well, and just listened.
Amazing.
And then we sent out a survey. We didn't have any money to do it. So I just sent out a survey and hoped people would respond. We got an amazing response. We got over 900 enrollees answering questions for us, again, about their health, their wellness, and what would make a difference from an investment perspective. And some of what we heard, I heard higher rates of food insecurity in our population than I have ever heard in
Wow.
any population, including Medicaid. The rates were up to 40%, 40%, for Spanish-speaking folks with a chronic condition, agnostic to income level. So that was where I was like,
Yeah.
what is happening? And our population are just living on the margin. It really is folks who don't qualify for a lot of other benefits because their income's a little bit too high and have a lot of costs in California. It is expensive to be here.
Yes.
And so we asked, okay, once we heard that, we said, oh my gosh, once you hear something you have to figure out, you're compelled to do something about it. And so we asked, well, what could we do that would make a difference? And folks were like, what? Any help you could give us for food, for transportation, for utilities. And because food insecurity had been so high and really cross-cutting, that's one of the population health investments that we're funding. We're giving folks a cash card that reloads every month. It scales up based on the size of your household. Just buy the things that you need. There's not a bunch of restrictions. It's not only apples or whatever.
Right.
You just
You
you're
trust
saying
the consumer.
we trust them. Autonomy, right? You're telling us you're hungry and you don't have enough money for food, and we are trying to just meet that need for you. So that's one of the population health investments, and we are actually doing pretty rigorous evaluation of it. There'll be kind of an embedded randomized controlled trial. We have academic partners who will help us evaluate it. Yeah.
So cool. This is super exciting.
So we'll learn how best to help folks, which to me is the most important thing. And we'll publish on that so others can learn too.
I mean, even just the act of having cash to rely on regularly probably has other health benefits too. Just that stress reduction. I mean, we know that's systemic, that can have big impacts.
That's exactly right. And I think when I was in conversation with maybe folks that were not as supportive of this idea, I said, we already know folks are telling us that they're making financial trade-offs by relieving, something over here. You actually are going to increase health-seeking behaviors and the ability to go to the doctor and get the care that they need, because they're telling us they can't do those things because of these other financial barriers. So I think that's exact. People know how to balance their own budgets and what's front of mind, and let's give it a try and then see what happens in result.
Okay, this is so exciting. When can we look forward to hearing how it went and what you've learned? That would be really fun to circle back and hear more about it.
Yes. So we're going live in February somehow.
Yeah. Okay. Exactly. I know. Just a couple months away. Right.
February is the go live, and the first prong of the population health investments will run for 12 months, but we'll be doing surveys along the way. So, I mean, probably like 3 or 4 months after launch, we'll have really good data on how many folks when we called them, did screen in for food insecurity. What are some of the early results that we're seeing? And, what are they are they spending the funds every month? Are they not spending the funds? So we'll have some of that pretty early on.
Okay, super cool. I wonder, did you also do any kind of investigation on like data from the pandemic times when there was money sent to folks
Yes.
to help? Was there any evidence there that supported this strategy?
Yes, absolutely. I mean, there all of these sort of like the child tax credit, the pandemic funds, we know what works. Actually, those are the largest scale interventions we've ever seen across the United States. And immediately you saw people's stress go down, their ability to kind of stay employed, right? Because sometimes there's a stop like, oh, you give them money, people will stop working. There's no data that suggests that actually really happens, not any strong data. And then absolutely, you do see some, depending on the study, different improvements in health-seeking behaviors and health outcomes.
Fantastic. Well, good luck with that, getting that
Thank you.
going. There was something else I remember when we first talked. This may or may not be something you're pursuing, but there was some discussion about investing funds for children.
That's it. Yes, good memory. We're also that's the second of the three population health investments that will launch in February. So this one was a little bit more out of the box, where we're thinking we don't want to be redundant to what the providers and the delivery system are doing. We don't want to be redundant to what the health plans are doing. We want to take this opportunity to invest in something that maybe hasn't traditionally been invested in. And so that's this idea of how far upstream can you really move to keep people healthy, not even have them have chronic conditions. And so the state of California has started a program where every kid, regardless of income level, can claim a child savings account from the state. Not my program, right? Just from the state. So that started in 2022. It's like any kid born after 2022. But the uptake of newborns has been actually a little bit low. And I think it's just been hard to like catch those new babies. And so we thought, well, we've got babies and we want them to be healthy.
Yeah.
And so we are actually, every kid under the age of 2 that is on Covered California, we're going to be outreaching to those families. First of all, letting them know about this opportunity to already claim their account. And then we'll be adding up to $1,000 more into each kid's account for them, tied to them going to well-child visits and getting some of their vaccines, trying not to be, overly burdensome, but encourage them, to do these good health-seeking behaviors. So yes, that's also February.
That's so cool. Yes. I mean, honestly, it just feels like a good investment.
Exactly. And the data is so clear. When I saw the data, I was like, what? The, increase in matriculation to 2- and 4-year colleges is like significantly higher, and you don't have to put that much money in the account. Once you get to $800 in the account, kids are more likely to get educated, which we know is a path to upward mobility, which we know is a path to health.
Right. Super cool. You were on a panel at Health on redistributing healthcare dollars. Yes. So interesting. And one of the discussion points was around prevention and sort of investing in prevention. Commercial health plans are disincentivized from investing in that because patients aren't with them for very long. It's on average 3 years, I think. People move jobs if you get it through your employer. Given what you know and what you're seeing, do you believe this is a straightforward argument for a single payer who's covering lives for the long haul? Like, what do you say to that? And I know we're talking about a new White House and different priorities, but is it a very straightforward argument for a single payer?
So it was an interesting panel. I agree with you. And, our churn is even higher than what you just quoted. Ours is about 15 months.
Oh, wow. Okay.
Yeah. The folks come in, we're really meant to be a bridge to employer or other types of coverage. So this is a particularly fascinating question for us as an active purchaser. And part of why I think that collaborative between Medi-Cal and, CalPERS is so important is it doesn't matter who is your purchaser, what plan you have. Like, we've decided that those things are important, which is sort of what you're saying, right? Is like, could the purchasers all be aligned on this?
Right.
What I said on the panel and what I will say today is, regardless of how you feel about single payer, I think we as Americans have decided that when there is a true market failure, that's where we want government intervention, right? Like, if the market can do it, let the market do it. And in prevention, unfortunately, it isn't clear that there's always an ROI, right? Most of us are not going to be super expensive to the healthcare system. And so doing excellent things for us doesn't save, frankly, anybody any money. It just costs money. Well, what kind of free market intervention can you have in a circumstance like that? You either have to incentivize folks doing that, a la electric cars or, things like that. Or you have to have government intervention. And so I think this is just the facts and what we in America have done historically. And I think it's up to us to decide if we have the will to either incentivize it in some different structures or have a government intervention that does support that. So, I think there's a few different paths to get there. This, what I told you about today is our attempt to try to do that in whatever micro way we can. And I think the rest is up to us, frankly, is how vocal will we all be about our desire to not just have sick care.
Right. Absolutely. Because it's expensive. It's unsustainable. We don't have the workforce to do it. There's all the pressure points. So it has to be done. Just how?
Yes.
So going back to your roots and maybe your educational roots, I was looking at that you have a degree in anthropology, an undergrad degree in anthropology, and then you went on to get a medical degree. Is there a connection between anthropology and medicine that you saw at the time? Was it tell me about that decision process. And I have a college student daughter.
Yes.
And so she's been deliberating between things. And it's so exciting to be on this side of that process, to parent somebody going through it. But it's cool to see where you are. You've made such an incredible impact in the work you're doing. And looking back, I'd love to hear how you made that decision to pursue medicine after doing anthropology.
Well, I love your parent lens, because I will say my dad wasn't that pleased with my choice at the time. Even what are you going to do with that degree? But
I'll figure it out.
Yeah, I was like, I'm going to see. I love studying anthropology, and it's true that there's sort of a niche piece of it that's medical anthropology. And I just remember starting to learn about a little bit of its medical history, but also intersecting with like what was happening culturally at the time. Frankly, all the things we'd gotten wrong.
Yeah. Yeah.
Like, we'd done a lot of stuff that ended up being really harmful to people and dangerous. And at the time seemed like it was A+ care and medicine. And so I think for me, because I'm a primary care doctor who's mostly practiced in Medicaid, systems, this idea that I'll never have all the answers, and that I truly am meant to be, yes, and know that like I come with my own particular lens to the situation. Some of that is like the Western medicine lens. Some of it, of course, is my own background, due to the times that we happen to live in right now. And then there's a person in front of me that has their entire own lens, and it's their body and it's their choices. And I'm here as a consultant to try to provide information that hopefully is useful to them. So to me, it feels very connected. And I hope that ultimately my dad believes that I made the right choice.
He should be very proud of you. Absolutely. Well, no, I mean, even it's so wonderful because you have that cultural sensitivity. That early training is definitely applicable to the work you're doing, certainly as you see patients on a daily basis, but also as you design programs to serve a diverse population. And that's why I wanted to know, because I wondered if it was sort of intentional. Like, I see myself in medicine, but I'm going to do this first because I get to do this in my undergrad, and I'll spend all those years in medical school.
It was definitely that, especially because I was good at science, I guess, but it was a little bit boring. So to be able to do some of the other pieces of it I think, made it for a phenomenal experience undergraduate.
Awesome. So cool. Speaking about like your journey to where you are, I'm curious if you overcame any barriers yourself, and was your resilience tested anywhere along the way?
Yes. Well, many, many, many times along the way. One of the things that was sort of funny is I was already well into my career as a physician leader when we were rolling out within LA County some questions around screening for social determinants of health. So we were testing, what questions should we ask? Which ones are validated? And so we were looking at one around housing security and housing insecurity. And I was like, oh my gosh, like I screened positive to this for most of my life. And it had never entered my mind that I had been housing insecure, and actually a number of other things as well, actually all the way through college.
Wow.
And so, I was a Harvard undergrad, and my mom was really living in very unstable circumstances. So I came home for spring break, and sometimes I wouldn't even know where she was and where I would be staying for that particular spring break or wherever I was. But I was very late in life before I was like, oh, is this me? Like, am I like underserved community?
Isn't
and
that
I think that's very interesting. And I mostly, again, because of where I sit now and the things that I have in my life and the way I'm able to move through the world, I have so many privileges and so grateful for that. And because I do still work in the county, I really do see folks that continue to be very marginalized in ways that I am not. But yes, now in retrospect, along the way, there's a lot of hurdles, I think, to overcome, although I also had a lot of support from people who loved and cared about me.
I'm curious about, it does sound like you prioritize obviously helping others, but as a mentor to others, do you mentor other folks? Do you focus on people in medicine? Tell me about that for you.
I hope that people would say that I mentor other folks. I think I myself have had amazing mentors and sponsors. And I remember one really saying that being accessible and available has been one of their greatest gifts from their mentors. And so I thought about that a lot. And now because I'm in a slightly more visible role, I get a lot of inbounds, right?
Yeah.
Funny ways. And I try to be accessible and responsive because you just never know what you have to offer that might be useful to that person on the other side. So I do, in a more formal way, I'm still on faculty both at UCLA and at Charles R. Drew, which is a historically Black medical school, and to spend a lot of time thinking about, certainly in medicine, those folks in the pipeline. And that's the future for all of us. So I really try to invest there. And then whoever happens to make their way to me, I try to hold close and let them know, whatever I can do for you in whatever way. You want to come to Thanksgiving, come to Thanksgiving. You want me to read a personal statement, I'll read a personal statement. And we, of course, host interns that cover in California, too, because I do believe that's part of our mission and responsibility. So, yeah, I consider that a really important part of my responsibility.
Well, I admire that so much. We are just thrilled to get this opportunity to talk to you because I know you're doing really important work and it's very exciting and I wish you well. I know that there's a lot just getting off the ground, so good luck with that. Please come back and give us an update. We'll maybe check in next year and let's all hope for the best. And thank you.
Thank you. I would love to come back.
Thanks so much, Monica. Thanks for joining us for the Game-Changing Women of Healthcare, a production of the Krinsky Company. Today's episode was produced by Calvin Marty, Chelsea Ho, Medina Shabich, Wendy Nielsen, and me, Meg Escobosa. This podcast is engineered, edited, mixed, and scored by Calvin Marty. If you enjoy the show, please consider leaving a rating and review wherever you get your podcasts. It really does make a difference, and share the show with your friends and colleagues. If you have any questions, comments, or guest suggestions, please email us at podcast@thekrinskyco.com and visit us on the web at thekrinskyco.com. Interested in supporting this show and reaching our engaged audience? We're looking for sponsors for this season. Help us put the spotlight on women leaders in healthcare. Email us at podcast@thekrinskyco.com. And thank you.